Shared decision-making in behavioral health. Although shared decision-making has its roots in medicine, the practice is migrating into behavioral health. In fact, the National Academy of Sciences has cited shared decision-making as one of 10 rules to guide the redesign of mental health and substance abuse care in the 21st century. Hi, my name is Pat Deegan, and in this video we will learn how the principles of shared decision-making are a good fit for behavioral health. Those of us diagnosed with psychiatric conditions face many decisions about treatment on our journey of recovery. Perhaps the most frequently encountered decision point are those about using psychiatric medication. Decisions about psychiatric medications meet all the criteria for being preference-sensitive decisions. That is, there's more than one reasonable option when considering the use of psychiatric medicines. Psychotropics within a class have similar effectiveness, but different benefit and risk profiles, and data to support one psychotropic agent in a class over another is equivocal, incomplete, and often open to interpretation. Because decisions about psychiatric medicines are preference-based decisions, there is an ethical imperative to involve people in a deliberative decision-making process. Consider this slide depicting one set of results from the CATIE study. Along the x-axis, we see 5 different antipsychotic medications: olanzapine, quetiapine, risperidone, profenazine, and ziprasidone. On the y-axis, we see the amount of weight gained per month. Although these 5 medications were found to be comparably effective in terms of symptom relief, they varied significantly for risk of weight gain. Choice of antipsychotic agent is a classic preference-sensitive decision. In order to avoid preference misdiagnosis, clinicians must include individuals in making the choice about using antipsychotic and other psychiatric medications. Remember, decisions about treatment are not just psychiatric decisions. Decisions about treatment are also personal decisions. For preference-sensitive decisions, it is not enough for clinicians to make decisions on behalf of individuals or to actively persuade them. The choice to expose oneself to medication-related risks, such as weight gain, sexual dysfunction, serotonin syndrome, tardive dyskinesia, agranulocytosis, cardiometabolic syndrome, hair loss, etc., these are decisions that require shared decision-making. In this way, preference misdiagnoses are avoided, and clinicians match the right treatment for the right person every time. Almost everyone would agree that choice of medication within a class of medications is a preference-sensitive decision. But what about the decision to use any medication? Is the decision to use or not use psychiatric medication a preference-sensitive decision? Assuming decision capacity, is the decision to not use an antipsychotic medication a preference-sensitive decision? Or is prescription of an antipsychotic a gold standard for the treatment of psychosis, and therefore shared decision-making does not apply? In your viewer's guide, you will find discussion questions and resources that will help you dive deeper into this important question. We assert that the choice to use an antipsychotic is a preference-sensitive decision, and shared decision-making applies. Antipsychotics can be very helpful tools in learning to effectively manage psychotic symptoms. Many studies have established the effectiveness of antipsychotics, and there can be significant risks associated with not using antipsychotics. However, these medications also have significant risks. There is considerable debate in our field about dosing and duration and the role of antipsychotics in treatment of first episode psychosis. Further, some people recover without medications, while others do not benefit from antipsychotic medications. What we need is a robust decision aid for young people and their families to support shared decision-making about the use of antipsychotics. Until such time, we must do our best to help individuals and their families understand the benefits and risks of using or not using antipsychotics. We must lay out all the options for treatment and help people understand their values and what matters to them. Learning to use psychiatric medication optimally in one's recovery process is a journey that takes time. Shared decision-making builds the therapeutic alliance and keeps clinician goals aligned with those of the individual and family. In addition to medical decision points, there are other types of decision points in behavioral health. For instance, there are social decision points, such as deciding to return to work or school, deciding to apply for SSI, lifestyle modification decisions, such as beginning an exercise program, decisions related to moving from one level of service to another, deciding when to disclose a psychiatric diagnosis at work, when dating, or at school, deciding to get a credit card if there is a history of bad credit, safety planning, decisions about where and with whom to live, decisions about representative payees and money management arrangements. All of these decision points are preference-sensitive decisions and require shared decision-making if they are to be addressed within psychiatric treatment. Additionally, in behavioral health, there are both crossroad decision points and continuing care decision points. A crossroad decision point is characterized by decisions that can't be undone. Examples of crossroad decision points might include the decision to have ECT or the decision to use a new medication, the use of psychiatric meds during pregnancy, the decision to have psychosurgery for intractable OCD, the decision to go off SSI and return to work, and the decision to disclose a diagnosis to an employer are other examples of crossroad decision points. Another group of decision points in behavioral health can be characterized as continuing care decision points. Continuing care decision points often involve making adjustments in the course of an agreed-on treatment path. For instance, once a decision to use a medication has been made, treatment is often adjusted and refined. There are ongoing decisions to continue, reduce, or raise dosages. Similarly, once supported employment has been chosen, there may be a number of ongoing decisions that must be made in order to match individuals with the right job. Shared decision-making can be used for both crossroad decisions as well as continuing care decisions. However, formal decision aids are typically developed for crossroad decisions. As we'll see later, other complementary decision support techniques can be used for shared decision-making at continuing care decision points. The issue of acuity of symptoms and consequences of waiting can be an important consideration in applying shared decision-making. Sometimes it's desirable for decisions to be made more quickly. For example, when an individual is experiencing a high level of distress. In other situations, we have the luxury of more time to support deliberation. For instance, consider a young man who has troubling and distressing symptoms and has decided to take an antipsychotic medication. He and his doctor are using shared decision-making to decide which medication to take. Since he is suffering with symptoms, it would be better if he could decide more quickly which medicine to take in order to try to get some relief quickly. This does not mean that shared decision-making is not used. Rather, it's done with the awareness that there are pros and cons to taking more time to decide. The issue of decision capacity is important in any discussion of shared decision-making, but especially when applied to behavioral health. Studies have shown that people diagnosed with schizophrenia have higher preferences for involvement in treatment decisions than general medical patients. However, do people with psychiatric conditions have decision capacity? The CATIE trial helps us understand that for most of the 1,158 research participants with psychosis, decision capacity remains stable or improved over the course of the 18-month study. 4% of the participants fell below criteria for consent-related decision capacity during the study. 1/4 of the participants had a period where decision capacity worsened, but did not fall below capacity to consent to participation. What we know about the decisional capacity of individuals experiencing first episode psychosis is limited. It's possible that young people who are experiencing psychosis for the first time may have more difficulty appreciating the extent to which some symptoms may be having an impact on their decisions. Nevertheless, lack of capacity should never be assumed. I think it's fair to say that we can have relatively strong confidence in people's capacity to participate routinely in shared decision-making. There will be times when individual decision capacity may fluctuate. In such cases, psychiatric advance directives can be helpful in safeguarding individual preferences until capacity is regained. However, decision incapacity will be the exception rather than the rule. With the help of carefully crafted decision aids and clinicians trained in the practice of shared decision-making, we should set the expectation that all individuals and their supporters will participate. At this point, you may be wondering if shared decision-making is applicable in situations of compulsory court-ordered treatment. In such situations, courts establish certain non-negotiables, such as adherence to long-acting injectable medications. I think the answer is that within the non-negotiable zone, there is plenty of room for respectful collaboration and shared decision-making. Many of the decision support tools that we'll review later have applicability in such situations. This is Pat Deegan. Thanks for listening, and I hope you'll join me in bringing shared decision-making to behavioral health care.